and sometimes I didn't. So that's just there is for your own amusement. One thing I would say on page 2 is that if you are dealing with peds or young women, think about bone health, okay? Because you all are still in that growth period. Take care of your bones. You're going to hit the peak here in about 30 to 35, and then it goes downhill. So pay attention. Do everything you can to good bone health. So what is good bone health? What will get you good bone health? Exercise will do it, yes. What?
Calcium, vitamin D.
Calcium and vitamin D, sunlight. What else? What do you not do?
Smoke.
Don't smoke.
Ooh, yeah.
Don't smoke. So you said sunscreen. Well, if you're going to use sunscreen, then if you need to use sunscreen, then use a supplement. What else? Anything else? What?
Long-term steroids.
Long-term steroids. So the men are protected. Here is the one time that being a male is in their favor. And so it's just, but it's time. It's time. If you live long enough, you'll get osteoporosis to some extent. But there are indications, and as we go through, we'll point those out. So in terms of using these products, we use them to either prevent or treat for osteoporosis in women, or we use them in men, or we use them in glucose-induced osteoporosis. Those are the 4 indications. So it's important that you know for each of them. I will hold you accountable for those. Okay. All right. So going over to page 5. So non-pharmacologic, I know you all talked about this. So the calcium and vitamin D, we talked about promote a bone-healthy lifestyle. A lot of it's just moving. If you stress bone, it will build. Okay? That's why usually heavier people have stronger bones. They carry more weight. But get out there and walk, even just walking. So some type of weight-bearing activity. Consider drugs. So let's go under there. So vertebral fractures you probably talked about, or hip fractures. Those are our 2 big things we're looking at. We're assessing, especially with the Price tool. We're going to use DEXA scans and scores also. So those T-scores become important. So we're going to look at what the percent or risk is of hip fracture, percent, and then what the T-score is. So low bone mass, we look at a 10-year probability of a hip fracture and 10-year probability of a osteoporosis-related fracture. Why do, I know I saw her slide, why do we worry about fractures so much? She called them a huge, huge event. They are life-changing events. What's the percent of people who die after a hip fracture? 25%. 50%. One that she said 50% have to go either into some type of assisted with family or into an assisted living type of arrangement. So that is huge. So in terms of pharmacologic prevention and treatment, we've got calcium and vitamin D. We're going to go through that briefly. In prevention of osteoporosis, we have the bisphosphonates, we have raloxifene, and we have hormone therapy, so we can use low-dose estrogens. Or treatment, we have the bisphosphonates. So you see them show up in both. So it's important to know bisphosphonates will prevent, they'll also treat. Raloxifene, prevent and treat. And then we've got some of the big guns. So these are the Navarone guns. Denosumab, which is Prolia, Teriparatide, the new one, Abloparatide, for high-risk fractures. All right. So non-pharmacologic, so bone healthy lifestyle. You got most of them. Smoking, limit alcohol, so lots of alcohol will do it. A well-balanced diet, calcium and vitamin D, and weight-bearing exercises, and fall preventions. So I think you've heard fall preventions before. We're going to go through them again. I know one of the speakers did. Dr. Britton will hit it again in geriatrics. It's so important. As people get older, they just forget. They get used to their surroundings, and then one day, that loose rug, stuff thrown in the, in the way, that curb that they didn't see, they don't have their glasses, and one misstep and a fall takes them out. Calcium and vitamin D, I gave you this same ability to calculate in nutrition. Most of you did not take in enough calcium. And I know that all of you have rectified that since that's been pointed out to you. Do it now. Make sure you get enough calcium. If you don't eat dairy products, then take a supplement. Know on the next page, know the amount that is for each of those age groups. Remember, we talked about this elemental calcium. So the recommendations are based on elemental calcium. All of the calciums come as salts. Okay. So calcium carbonate is what percent calcium? 40%. Know that. I will ask you to calculate. So Tums is calcium carbonate. It's an easy one. The other alternative, if you look on the next page, where did I put that? Look over on page 10. Calcium carbonate, calcium citrate. I would keep calcium citrate in mind. If you look over there, it's about half the percent of elemental calcium is calcium carbonate. But here's the difference. It is acid independent. So you can take it with a proton pump inhibitor, or if they're on a proton pump or some type of acid suppressant. You can't do that with calcium carbonate. It needs to be taken with meals to get best absorption. Keep those in mind. I guarantee you I will ask you something. It's important. It's important to know. Okay, back to page 7. Smoking habits. So all those things we talked about in pulmonary about smoking cessation. What were the 5 A's? What was the first of the 5 A's with smoking cessation for a provider? Ask. Okay, so ask and assess their smoking, especially teenagers. Okay. Exercise, we talked about that, increases bone mass. Get moving. Let's look at fall prevention again. This one is important. Medication review. Often people who are older are on multiple medications that affects their balance. Okay. So having a pharmacist, if there's one in your practice or group or someone, especially if you see a lot of things on their medication list that you think are putting them at risk, get a pharmacist to give you some guides about what you can do. What would be drugs that would make you think about fall risk? Okay, so antihypertensives, okay. Benzos, painkillers. So something that enters sensorium or changes their balance, be aware. Ask about alcohol. Did you have another one?
I just said alcohol.
Yes, alcohol. So mixing those together could be a problem. Remember that their liver may not be able to metabolize, or their kidneys as well, and so drugs may hang around longer. And so you look at it, it looks pretty normal in terms of dosing, but it could be too much for them. Vision correction, it's important. If you can't see, it's harder to keep from tripping. Make your home safe. I think Dr. Britton will have did he have an OT person come in before? See, we've moved we've moved when these were, so I keep forgetting when we did what. He may, have you had an OT? I think he brings one in geriatrics too, and they'll tell you about how to set up your home. You can have somebody who come in and look at your home and tell you where it is unsafe. But you can do simple things like, do you have a clear path? Throw rugs. If there are places in the house that are uneven, you know, sometimes you have those tri and bi-levels. Okay, so marking those and making sure the stairs look different from the floors below and above will be helpful. The other one that has come to mind for me is our flip-flops. So I've been reading more about them, but I had a lady in the choir that sings in the choir with me, And she had a terrible fall, and she tore up her both shoulders badly. And I said, what happened? And she said, I was carrying something from the car to the house, had on my flip-flops. Flip-flop caught on the concrete, and there she went. With her hands full, she couldn't brace the fall, and tore her shoulders up. Flip-flops. Staying active in exercises, using those ability to maintain balance. So there's all kinds of, has Maria Jones come and talked to you about balance? They may do that in geriatrics. So there's all kinds of ways balance exercises. Like those silver sneakers I told you about in nutrition, they work on balance exercises. Yoga, that tree thing. That's a balance exercise. Okay. All right. Okay, next page, page 9. Questions about those? So those go a long way. Those are always should be gone over and encouraged with those. Okay, so the first ones we're going to look at anti-resorptive therapies. So therapies that keep the bone from giving up calcium. So those would be the calcium that you have them take, vitamin D, bisphosphonates, the estrogen, agonist, antagonist, denosumab, and then testosterone. Let's see. Mostly, I don't think I'm going to skip most of this. Couple things with the dosing on the calcium. Know the recommendations. Know how to figure it out in terms of what, and more I'm saying that is that for your patient. So keep things that can help them calculate how much calcium they're taking in. The other is to keep in mind is that the absorption is dose related. So 600 milligrams and below is better absorbed. You'll get more out of it than you will if you take all the calcium at one time. So spreading calcium out throughout the day is better than trying to take it all down at once. Don't exceed the upper. So more and more is not better. So the upper tolerable dose is recommended 2,500 milligrams a day. Vitamin D is really important since we've got so sun phobic and we've gotten these higher and higher SPFs. It's important to, like Kristen pointed out, is that if people are always covering themselves, like older people do, what do when they go outside? They wear a hat, they wear long sleeves, they wrap themselves up, they wear gloves. Okay, so if they're doing that all the time, then they're probably not going to get any sunlight absorption. What's the other about sunlight exposure and skin tone, skin color? Darker skin needs what? More. So Paul probably gets all the vitamin D he needs walking from here to his car. Yes. Okay? So the fairer you are, 15 minutes a day, he's good. Okay? So people, the darkest of people probably need almost an hour of sun exposure. So think about it, especially your African Americans, look for decreased vitamin D. Do your vitamin D levels on them. Okay. Any questions there about, the vitamin D formulations, let's talk about those. So over the counter you can get vitamin D2, which are in supplements. Vitamin D3 is more what you make. When the sun hits the cholesterol, that bad cholesterol in your skin, that converts then to D3. And then what happens from there? You get what organ interacts with it next? Kidney does it second. What's first? Liver. Liver hydroxylates, so it puts a 25 hydroxy on it, and then the kidney does it again at the first position. So you get 125 vitamin D. If you're going to replace, you can use either one. Some people prefer, or you'll see experts prefer the vitamin D3. Okay. If you have severe levels, then you can give big doses, right? It's fat soluble. So who is going to be at risk? Who is going to be, pardon? People are inside all the time. Who else vitamin D?
Skinny people.
Okay, skinny people, all right. They still have fat stores that they can store. What else? Who won't store fat? Who's not gonna absorb it?
Oh, people with GI, like malabsorption.
Okay, so any kind of malabsorption syndrome, bariatric surgery, okay? A, D, E, and K, they're going to be at risk for not absorbing. Your pancreatic insufficiency, if they're not taking their supplements, they can't absorb fat. Okay? So look for those folks as really high risk. So there you can do, I've had you do this prescription before, 50,000 units weekly for like 8 weeks. That will restore it, and then you can put them on a maintenance dose. There's real variability in what is normal. What's a normal vitamin D level? So you'll see anywhere from 30 to 100 as listed. All right, questions about vitamin D or calcium? Okay, let's talk about the bisphosphonates. These are considered first line. They inhibit bone resorption, they inhibit osteoclasts, which break down the bone, and they get incorporated into the bone, and they have a really long half-life. They stay there for 10 years. That's why even if we only treat for 3 to 5, they've still got residual effect for a number of years. Okay. There's a table on the next page, and I've given you the different indications. I've given you the for each of the agents, I've given you prevention dose, treatment dose, I've given you what it's indicated for, so you need to know, is a product preventative, is it treatment, is it mint, and steroid. Those are the ones. So that encapsulates. If it's bolded, I consider it fair game. So you've got alendronate, residronate, and zoledronic acid. These are indicated for prevention and treatment. Postmenopausal, male, and glucocortic and steroid induced. They hit in almost all of it. Now, abandronate is only indicated for prevention and treatment of postmenopausal osteoporosis, not for men, not for steroids. So they're very good at spine and hip, reducing those fractures. And they're great because they're daily, they're weekly, they're yearly. Okay? They have hit the market, they've found all those niches in the market. Contraindications you need to know. So contraindications are, one is if you can't sit upright for 30 minutes. So your old may not be able to do that. That is because these drugs can cause significant damage to the esophagus if they get stuck there. So if you have esophageal disease, you're not going to use these products. So think of it that way. If it gets stuck, it's bad. It can cause ulcerations and significant morbidity. So what would be esophageal diseases that you would think of?
Stricture.
Stricture. Barrett's esophagitis. Varices. Achalasia. Those would be your big ones. If they have GERD, and they don't have an esophagitis, I would not consider that a contraindication. But if they have severe enough GERD that it's caused strictures or swallowing disorders, yes. So any swallowing disorder, you would. The other big thing to remember is creatinine clearance, because you're mostly dealing with older people likely to have reduced renal insufficiency. Other drugs can be used in renal insufficiency, so we'll point those out. Hypocalcemia, you're always, for any of these drugs, you're going to check their calcium level before you put them on these agents. And then we're not going to use it for pregnant. Adverse effects on the next page, mostly it's GI, perforation, ulceration, GI bleed. So you can see why we're concerned about the contraindications. Not as much a problem if we're going to give it weekly or yearly. If we're going to give it yearly, we don't even care about the GI. And we're going to give it IV, so we're not even going to touch the esophagus. So IV abandronate, zoledronic acid, those are for people who cannot tolerate it orally or have GI indications. The big one is that osteonecrosis of the jaw. Did you all talk about that? Okay, this is a bad one. I have seen it twice, and I have seen one person die of it and the other have significant pain. So they get a necrosis of the jaw, The lady I saw that died went in, they had to do surgery because it was so bad. And it did occur after a dental procedure. And she died of complications of the surgery. So the people who are most at risk are those who've had something that has gone on with the jaw. So dental work is one. Cancer, chemotherapy, radiation to that area, steroids because they weaken bone are all higher risk. So it's rare, but I've seen it twice. And I saw it through the Coumadin clinic more than anything else. So choice of bisphosphonates, which one to choose? Well, we're going to start with the orals. Those would be our first. Residuronate and alendronate are the drugs of choice here because they both hit spine and hip. And they're oral. And they're generic. They're less expensive. Okay? And they're available as a once a week. So that's where you would start. You could do zoledronic acid if you need to. It's once a year. It's going to be more expensive. You could do a bandronate, but it is not. It's spine only. So hip, you'd have to have good hips, so you're not worried about hip. Let's see. Products we talked about. Okay, therapeutic use and doses on next page. You want them to take with a full glass of water. I have seen where, I think Residuonate's come out with an extended release product that requires less water. I didn't put that down, it's just something I saw at the last moment. You don't want them to lie down, you want them to get you want the drug to get down to the stomach and dissolve. Duration of therapy, how long to use? Low risk, 3 to 5 years. People are low risk for fracture. If they're higher risk, then it may be more indeterminate length of time. Okay. That's the bisphosphonates. Questions about those? Anything I said that contradicts what you heard on Tuesday? Okay. The estrogen agonist, antagonist, this is raloxifene, or Avista is the trade name. It has estrogenic effects on bone, so it builds bone up. However, it has negative effects it doesn't affect the breast. So if you've got women who are at high risk for breast disease, then this might be one to consider. So it can be used for prevention or treatment, but it's not as good as the bisphosphonate. It's not as good as the more high-powered drugs. It probably has a more of a special niche for people who, if you're wanting to, that can't use bisphosphonates or the other products are not needed. So efficacy reduces vertebral fractures, it increases bone mineral density, it does not cause endometrial, does not cause breast cancer. So those are your people to keep this one in mind. Women who are younger and don't want to take bisphosphonates forever, that is possible. Not for men, not for glucose or steroid-induced osteoporosis. Look at the contraindications. It causes hot flashes, so it's going to be problematic. VTE increase. Okay. We saw this with Duovi. Duovi is also a SERM. These are both selective estrogen receptor modulators, SERMs. Patients, this is where hip fracture is the primary concern. Where hip fracture is the primary concern. Sorry. Okay. So probably this one's going to be more of a special niche. It's once a day, it's oral. Okay, hormone therapy, next page, page 13. This is for prevention only, so not for treatment. It's pretty good, reduces fractures by 33 to 40%. You're not going to use the rings or the vaginal products. Here you use probably a patch or a tablet. There is a particular patch, the Ministar, under dosing and administration. Ministar has FDA approval for use of prevention. It's only 14 micrograms per day, and it is so it's considered one of the ultra low dose. Don't have to use progestin with it if that's all they're using. and it's a weekly patch for prevention. Again, it's it's the only one that's got that for prevention. If you're using estrogens for other reason in a woman, then that also can be helpful in terms of prevention. Make sense? So you're not going to start a estrase tablet in someone like this if that's all you're treating. If you're treating for hormone replacement therapy, then you're also going to get the bonus of prevention. See the difference? Okay, but this one has an indication. It's the only one. It's the only estrogen product that has that indication. Placed in therapy, not first line, only used in women who need hormone replacement for menopausal symptoms. Not recommended for men, duh, or steroid-induced osteoporosis. Questions about where that fits? It's kind of a little bit of a difference. We say we're not using it to prevent disease or treat disease. Well, here's one place where we are. Prolia, denosumab. This is one of those rankle. I think Dr. Vanetta, because one day there was stuff like, he always leaves stuff on the printer. He never remembers. He prints it and he never goes and gets it. So usually, and a lot of us do that, so we're sorting stuff out, and here I see a rankle, or a rank, and I thought, and the world is looking at that. Then it was Dr. Vanetta, what were y'all doing?
Musculoskeletal.
What?
Musculoskeletal.
No, I think it was an adrenal, or
Hypogonadism.
hypogonadism, maybe. Pardon?
I thought it was musculoskeletal, we were talking about
Yeah.
It was when he taught. Did he teach
Yeah, we talked about it.
Okay, then it was probably there. Okay. So look at the bottom. So the wrinkles, so the L on the end is ligand. What's a ligand? Binds to a receptor. Anything that binds to a receptor is a ligand. So Prolia is a rank ligand. So those rank receptors sit on osteoclasts. And when they interact, when that ligand interacts with that receptor, you get an increase in osteoclast formation and action. So you start releasing calcium into the system. So this drug sits on that receptor and doesn't allow it to do it. So it's an antagonist. So it sits on the rank receptor, and so it shuts down bone resorption, so you get a decrease in bone resorption, bone mineral goes up, decreased risk of fracture. On the next page, I'm giving you another, because I always find lots of things I like, so if I find I really like two of them, I can't decide to put them on. So I like this, just gives you a different way to look at it, shows you where that receptor is, shows you the things that will inactivate it or activate it. So this is treatment only. We don't use it for prevention, so note that. It's one of the big guns. Now this is the Navarone side, okay? So these are women who have failed a bisphosphonate, won't take a bisphosphonate, high risk. Also, look at the other thing that it's good for, renal insufficiency. You can't use the bisphosphonates in renal insufficiency. When you get to a stage 3 and below or above, you can't use it. So this one can. So that's a plus. You can use it in men. You can use it in women who are getting aromatase inhibitors. Okay? So many pluses here, but probably more niche. So think about the specialized reasons for using it. It's very good at decreasing spine and hip. So adverse effects, back pain, musculoskeletal pain are probably the most common. Severe would be you get that osteonecrosis of the jaw. Again, it's down there, atypical fractures. Because you're remodeling the bone in ways that isn't normal. So some women will have fractures there. So another good thing is that it's only every 6 months. So they're going to have to go to the doctor and sub-Q injection, check calcium before. All of these, check calcium before you use it. So each time they go in, they'll have to have a calcium test as a recommendation. Questions on Prolia? Okay. Forteo, and also the new one, Timlos. So this is Teriparatide and Parathyroid. These are parathyroid hormone analogs. And I put this in here because last year when I taught it, we hadn't had diabetes, so students didn't know when I talked about a pen, what a pen meant. So both of these products come as pens that the patient it's loaded for a month's supply. They use the pen for a month and they get another one. These are like the biggest guns, so these are not going to be used in everybody. They'll never be first line for low risk or moderate risk. Now, people who have very high risk, high fracture risk, this could be considered a first line, but it will be in those very highest risk women, usually. Or it's not for men. So it's reserved for treatment of women who are at high risk for fracture. So only treatment, no prevention, no men. Next page. Increases bone formation. It's the only group that does that. So all the others are anti-resorptive. They keep those osteoclasts from working. These actually build bone. Okay, so this says, I wrote down no, not men on the other
So I
side.
think that F is still with the Prolia.
Oh, I bet it is. So that's me not paying attention. Sorry. Okay, let me go back and just make sure that it's true. I think you're right. Okay, so F is still with Prolia. Thank you. All right. Next page, page 16. So under treatment for postmenopausal women, men, and glucocorticoids. So if you're thinking about Prolia, do you ever see the commercials for it? It's always, what's her name? I'm trying to think of the actress's name. Anyway, it's always a woman who is talking about Prolia, so that way maybe you can remember that it's just for women. Okay, so Teriparatide. Okay, so this is for very high risk fractures. So look at the, so these are for people who have a history of fragility fractures. What are fragility fractures?
Fracture without trauma.
So usually it's due to something that produces a fracture that normally wouldn't, right? So something low impact produces a fracture that you wouldn't normally expect. So those are fragility fractures. Multiple risk factors for fractures, very low density, so a t-score less than minus 3.5. If they're intolerant of other treatments or have failed other treatments, that would be another indication. So a contraindication would be metabolic bone disease, so an active bone disease would be a contraindication. Paget's would be one. Elevated ALP phos, remember some ALP phos comes from where? Liver, bone, so you can fractionate it. All I can remember is bone burns, but I don't remember now what that does in terms of how you order it, but there must be something that then you add to the ALP phos. I don't remember how you designate bone only. Efficacy, it decreases risk of vertebral and non-vertebral fractures. Adverse effects. These are big in osteonecrosis, so they have a black box warning on them. They also limit the length of time. So if you're going to use these agents, the length of time is 2 years. If you use either product or both, it's still a cumulative of either of the products for 2 years. Either or both. Also, the osteosarcoma. So it has the black box for the osteosarcoma. So bone cancer. So they come as a pre-filled pen. They're given subcutaneously every day, 2 years. So I told you that it could be used initially for women with severe osteoporosis who have a T-score of 2.5 minus 2.5 plus a fragility fracture. These are brand new. These came out just in the spring. So write these down. So indication for initial therapy for women with high risk or severe osteoporosis, T-score less than or equal to minus 2.5 plus a fragility fracture, or their T-score is less than or equal to minus 3.5 in the absence of fracture. Okay, see the difference? Okay. These are high cost items. So if they were putting dollars like they do for restaurants, this would be $5+ dollar signs. Forteo is $36,000 a year. Now the new one, that Timlos, is about $20,000 a year. So don't be surprised if the insurance companies don't push back, or they're going to want documentation of why you're going to do this. Prolia is $2,000 a year. The bisphosphonates are about probably 150. Phone, you or Kristen, about the bisphosphonates. I think they're about 150 a month.
They weren't that expensive.
Then that's the generics,
Yeah.
because the brand was about that when they.
We never even stopped wearing it. We only had generics.
Okay, well, that's because
Yeah.
they've been generic now for a few years. Okay, so that's why you may get pushback. Okay. I'm sorry, I will pay more attention to layouts when I move stuff around. I think that's it. Questions? Anything I told you that you didn't? So that was different from what she said on Tuesday. I went through her slides. It looked like we were pretty compatible. So the big thing is, how do things work? Treatment or prevention, type of fracture, and those are going to be the big ones. Side effects.